Hello, I'm Gavin Nyman. I'm an orthopaedic surgeon specialising in shoulder, elbow and hand surgery. I work in Adelaide at the Queen Elizabeth Hospital in public practice. I also consult privately in Glenelg at Glenelg Orthopaedics, and in the north at Mawson Lakes, and in the Fleurieu Peninsula in Middleton. Today I'd like to address the assessment of neurological conditions of the upper limb, in particular the two most common conditions, those being carpal tunnel and cubital tunnel syndromes. I'll start by stating that my approach to assessment of any area is to divide it up into simple packets of information, thus making it easier to remember. When it comes to assessment of the spinal conditions, in particular neurological conditions involving the upper limb, my approach is to consider the nerve injuries by the site the injuries can occur. While the nerves start in the brain and exit in the spinal cord and then form through a plexus into the main nerves going to the arm, common injuries occur either centrally or peripherally. What I mean by this is that nerves to the upper limb can be affected in the neck as they exit the spinal cord, centrally, or otherwise one of the main nerves that supply the arm can be affected, those being the median, radial and ulnar nerves, the peripheral nerves. Knowing what these nerves do is really important in helping make the diagnosis. Centrally, the five spinal nerves are the C5 nerve, which supplies sensation on the outer aspect of the upper arm, C6 nerve that supplies the outer aspect of the forearm going to the thumb and index finger, C7 supplying sensation on the front of the forearm going to the long finger, C8 that's supplying sensation on the inner aspect of the forearm going to the little finger and part of the ring finger, and T1 supplying sensation in the axilla and the upper arm. These same nerves provide motor supply or movement to the arm, C5 in abducting the arm, the C6, 7 and 8 nerves on bringing the arm down to the side, C6, 7 on flexing the elbow, C7, 8 on moving the wrist, and T1 on moving the fingers. Conditions that affect the spinal nerves will affect the arm in these areas with associated weakness and sensory changes depending upon the nerve root itself affected. Along with this, there also may be some associated neck pain. The most likely causes of central issues are spinal disc prolapses or arthritis in the neck, which can entrap the nerves. Peripheral nerves supply sensation in the forearm, with the radial nerve supplying sensation on the back of the hand, the ulnar nerve supplying sensation on the inner aspect of the hand with and part of the little and the ring finger, the median nerve supplying sensation on the palm, index, long and part of the ring finger as well as the thumb. Muscle-wise, the radial nerve supplies or provides movement for extension of the wrist and index fingers, while the ulnar nerve leads to separation of the fingers, known as abduction, and the median nerve itself can affect movement of the thumb, particularly away from the palm, known as abduction. The two most common peripheral conditions that can occur are neurological symptoms and lead to neurological symptoms in the upper limb are carpal tunnel syndrome, where the median nerve is trapped in the wrist underneath the flexor retinaculum, directly over the palmar aspect of the wrist, and also cubital tunnel syndrome, where the ulnar nerve is compressed around the elbow along the path it takes around the medial epicondyle region, which is in this area when not is known as hitting the funny bone. When a person has a carpal tunnel syndrome, they complain of pins and needles in the index finger, long finger and part of the ring finger, which is often worse at night time, or when holding a phone, or when driving a car. Now, it can often have some pain from going up the palm, up their forearm. The symptoms often require the person to have to shake their arm around, or at night time hang their arm over the side of the bed to try and relieve the symptoms. Cubital tunnel syndrome is where the person often notes pins and needles affecting the ulnar side of the hand, that being the little finger and part of the ring finger. The sensation is if they've knocked their funny bone. It's often worse when leaning on the elbow, and it can be associated with pain radiating down the forearm. Assessment involves taking a full history, being aware of the actual patient's age and any associated medical conditions, and then also examining the neck, the shoulder, elbow, wrist and hand motion. It's important to note which areas of sensory changes are present, and also muscle weakness. I start by assessing the neck, in particular the motion, including placing the neck in positions which would entrap the nerves to see if it reproduces the symptoms. That is extension, rotation, and what's known as abduction. And this can lead to actually nerves being trapped in the neck and reproducing the symptoms. Also assess sensory changes and motor strength in the limb. Assessment involves also testing for Tinel sign, which involves tapping along the path of the nerve to see if this triggers the symptoms. There are also special medical tests that can help confirm the diagnosis. Some people may have had an ultrasound of the arm to see if there are nerves that have been compressed in the elbow or the wrist, but a more accurate way is the nerve conduction studies, which are performed by a neurologist. That's where they place electrical signals down the arm and it's read further down the arm to see if the nerves have been compressed and if the conduction of the nerve is actually reduced. Just in much the same way as an electrician tests with a voltmeter. X-rays can be also important to exclude arthritis, which can produce extra bone and be depressing upon a nerve. An MRI scan of the neck can help us see if there are nerves being entrapped in the neck. It's important when assessing a patient to be aware of the patient's full history, including any other medical conditions, and also be aware that not all causes of pain in the hand are related to a trapped nerve. They can instead be caused by arthritis or by entrapment of the tendons themselves, leading to trigger fingers or thumb. Treatment of nerve conditions can be very effective and involves releasing the nerves which are entrapped. A carpal tunnel is one of the smallest operations undertaken by ourselves here at Glenelg Orthopaedics, and it involves releasing of the median nerve at the wrist through a 3 to 4 centimetre incision. This way it can be done under local anaesthetic or with some sedation if the patient wishes, but also is always done as a day surgery procedure. Under local anaesthetic, the risks are extremely low. For ulnar nerve entrapment, this requires a general anaesthetic because we have a slightly bigger incision and often move the nerve away from the area where it's being impinged. This is known as a transposition to avoid direct pressure upon the nerve. In the case of nerve entrapment in the neck, a steroid injection may be worthwhile to try and relieve the pressure being placed upon the nerve. But if this fails to work, then an opinion from a spinal surgeon is warranted, should the symptoms not improve with the time anyway. Consequently, when it comes to assessment of the upper limb for neurological conditions, I believe a dedicated approach to addressing the exact causation so as then to offer an appropriate intervention is always warranted. Please note that any further information can be obtained from our website at www.glenelgorthopaedics.com.au, and also please watch out for further videos or follow us on Facebook at Glenelg Orthopaedics for an update on any assessment of any other orthopaedic type injuries which we'll put up on a regular basis. Thanks again for watching, and until next time I wish you all the best. Thank you again.